3.
3:45.
Okay. Yeah. You want us to land by 3:45, is that right?
Yes, it's an hour and a half.
Yeah, right. Yeah, that's fine.
Thank you. It's my pleasure to introduce the moderator of our panel, Paul Bongiorno. As I said, Paul has been a part of public life for as long as any of us can remember. He's one of those people who you think you know. You wave at him in restaurants. I'm sure this happens to you all the time, Paul, but regrettably you don't know all of us. Paul is Network 10's contributing editor, a position he has held since he resigned as National Affairs Editor in 2014. Previously, he was the network's Canberra Bureau Chief and Political Editor for 20 years. He's a regular commentator on ABC Radio National Breakfast and a columnist for the Saturday paper and the New Daily. For 17 years, he was executive producer and host of the weekly political program Meet the Press. Paul has a master's degree in theology from the Pontifical Urban University in Rome. Thank you, Paul.
Thank you very much. Well, I've just dropped things. It's always handy to be nervous before you start rather than the end. Well, thank you very much for asking me to perform this task. I've been told that the format is more like a Q&A, which we see on the ABC, and I'm supposed to be something like Tony Jones, although he has more hair than me. So you've been sitting there listening to people this morning, very interesting people raising very interesting subjects. What we propose to do today is I will, of course, direct questions to the panel. That's why we've got them here. But we'd like you to direct questions to them, and we'll intersperse the next 90 minutes with, if you like, an interchange between all of us so that we're not just sitting there going to sleep after lunch. So we now come to discuss a range of the issues occupying all of you as delegates to this conference. We heard this morning from leading politicians, most crucially the Minister for Health, Greg Hunt, and as an innocent bystander, although a taxpayer and someone who visits doctors regularly, it does seem that Greg has sued for peace with the medical sector. There are now guarantees for Medicare, for prescription medicines, and the rebate freeze is thawing. Well, not surprisingly, as we heard this morning from Opposition Leader Shorten and his shadow minister, they're not convinced, nor are the Greens, that the thaw is anywhere near as fast as it should be. And I even noticed that there are some in the ranks of the medical profession, like Paul Mara, who wrote a piece in The Guardian the other day, who think that the doctors have been taken for a ride by the government with all these guarantees. Interestingly, I also discovered that Paul Mara doesn't come to the discussion, as it were, from the left, but more from the right. He would like to see co-payments and all that sort of thing. The big issues we want to discuss now are hospital funding, aged care, closing the gap with Indigenous health, and the future of private health insurance. We've got enough to talk about for the next 3 weeks, I'm sure. Plenty to stimulate. And on the panel, we have Ken Wyatt, the Minister for Aged Care and Indigenous Health. That's Ken with the yellow tie. Dr. Dwayne Crombie, Managing Director of Bupa Health Insurance, right next to me. Toby Hall, the Group CEO of St Vincent's Health Australia. And we have Dr. Michael Gannon, who you all know, he's your federal president. And the rose between all these thorns is Dr. Elizabeth Miles, and she's Senior Staff Specialist, General Practice, and former President of the Royal Australian College of General Practice. So, as it is Sorry Day, and we do have almost 200 delegates, Aboriginal and Torres Strait Islander delegates meeting at Uluru to discuss recognition in the Australian Constitution. So a happy coincidence, and of course the AMA, as I noticed Catherine King paid due deference to you, your organisation, has been leading in its advocacy for closing the gap and for Indigenous health, and I congratulate you for that. And I'm very happy to say that, again, as an innocent bystander, that Dr. Michael Gannon, your new president, is carrying on that great tradition. So I thought today that the first question should go to the winner of the Indigenous Medicare Scholarship, James Chapman, and he could direct a question to the first Indigenous Federal Minister, Ken Wyatt.
Hi, Mr. Wyatt. My name's James. I am a second-year medical student. During my education, we're taught about access and how access can improve outcomes for not only Indigenous people but all minorities across Australia. I'd just like to know what, in particular, your government's doing this year in order to improve access for Indigenous people in order to close the gap.
James, thank you. Congratulations on your scholarship, and thank you very much. Aboriginal health has been a conundrum for Australian governments at every tier, probably since 1972 in particular, when Commonwealth funding was made available and there was a focus on community health nurses providing healthcare to Indigenous Australians in remote communities in the top end of Australia. And then there was a reliance on health systems, state and territory health systems. But following the Whitlam and Fraser years, there was a focus on creating Aboriginal community-controlled health services, and we saw an improvement. But over the last 9 years with the targets for the Council of Australian Governments, it hasn't worked or delivered in the way that we thought it would. And so recently I want to acknowledge the AMA, and there are some individuals in this room whose passion for the status of the health of Aboriginal and Torres Strait Islander people has been outstanding, and I want to acknowledge them. But I think that we need to look at the number of Aboriginal people who access Aboriginal community-controlled health services and expel that myth that that's the only point, because data shows us that just over 50% of Aboriginal people go to their local GPs. So our GPs play a very critical role in their primary health care. The other area that I've not been able to tackle properly is the tertiary sector. So I've met with the presidents of all of the colleges, the Royal Colleges. On Monday, we're signing an agreement that arose out of that discussion about the way the colleges can influence the journey of Aboriginal and Torres Strait Islander people through tertiary care and seek to have far professional associations. And on Thursday, I said to them I want a partnership with them to increase the number of Indigenous Australians working within the various professions. So we've agreed on a strategy and an approach. I also want to focus on 0 to 17-year-olds, not just 0 to 5, but 0 to 17, because I want to tackle the issue of early teenage pregnancies, some of the rates of poor health, the issues of social and emotional well-being, and the levels of suicide. It's going to be multi-pronged, and we're looking at revitalising the COAG targets so that they're achievable. Child mortality is problematic because when I drilled down onto that, that was not only about child mortality in terms of health issues, but child mortality for road traffic accidents, for homicides, for drownings. Homicides and traffic accidents governments can't control. We can certainly influence thinking. So some of that work has to be undertaken. I just want to take a new approach and do some different thinking, but I need people in this room also to walk with me in that journey.
I wonder, Michael Gannon, whether you think that enough is being done to the extent that the AMA at the time of the last federal election put out 10 challenges to all politicians, not just to the coalition government, but to all the political parties. And your number one position, your number one marker was correct the underfunding of Aboriginal and Torres Strait Islander health services. Has this latest budget gone anywhere near as far as you believe it should go? And I suppose this opens up, which the panel can come to, the whole argument, is money the answer to everything?
Well, money's never the only answer, but sadly it comes with a lot of the solutions. So what we saw for many years was underfunding of Aboriginal and Torres Strait Islander health, and I'm pleased to say that we're now in a position where we've reached parity, but of course that's not enough because it's going to require additional investment to close the gap on these key measures. I think Ken's raised one of the really important points. He's raised, and he's a great supporter for Aboriginal control in terms of primary healthcare services. But he's partly raised the important point that for a lot of Aboriginal Torres Strait Islander people, they will just see their local GP. And then of course, when we're talking about the tertiary sector, they use the same services that non-Indigenous Australians use. So one of the uncomfortable topics that the AMA will address over the next 12 months is the issue of racism within our hospitals. It's a concept that's very difficult for us to look inwards and acknowledge that it's there. But we are going to need to see a lot of money in these areas. I'm pleased to hear Ken talk about the age of 0 to 17. The concept of addressing the first 1,000 days is so important. If women are healthy when they fall pregnant, if their pregnancies are planned, if they're taken good care of during their pregnancies, and we arm child health nurses and other key health workers with the ability to look after them for the first 2 years of life, that's possibly the best investment we can make. That's true of Indigenous and non-Indigenous people. But I'm pleased to hear Ken, a senior member of the government, acknowledge the issues. We have so far to go to close these gaps, and one of the areas the AMA is extremely strong on is recognising and acknowledging the social determinants of health which underlie Indigenous disadvantage.
Dr. Elizabeth Miles, it was interesting to hear the Minister say that basically a majority of the Aborigines go to their GPs, wherever they are. And of course, we're not only talking about Aboriginal health in remote settlements, we're talking about Aborigines in our capital cities. And of course, the gap is a gap that not only encompasses Indigenous Australians, but socio-economically deprived Australians. But do you feel that that GPs are alert enough, well-trained enough to the sorts of issues they have to deal with Aboriginal and Torres Strait Islander patients?
Well, as someone who worked for 15 years in a community-controlled health service, and now I'm working in a clinic where we've established an Aboriginal health clinic. I've had the opportunity to meet with a lot of patients, and I think that they are no different to anyone else in that they want to be treated with respect, and if they form a good relationship with their GP, they will be loyal to that person whether they are in a community-controlled service or elsewhere. In terms of the actual training, we're putting a lot of effort into general practice training. In fact, Aboriginal Health is one of the only mandatory components of the curriculum. Every regional training organisation is required to spend a significant amount of time upskilling the registrars in terms of Aboriginal health. For established GPs, I think our primary health networks have a key role, and they also have a key role in providing resources to assist GPs to help people get the outcomes and the care that they need. So, for instance, gap fees can be a really big barrier to people actually going and seeking specialist help, and being able to bridge that gap with funding is really important. Similarly, transport issues. Social work is a really big one because navigating systems is really difficult, and we now have, the NDIS, we have aged care, we've got a lot of pressure on people through Centrelink who are on welfare, and those things can create a lot of anxiety, which then can lead to mental health issues. So I think, we do need to take a very broad approach, and I think we are seeing that happen, but we need a commitment from the government to continue to work in this area. And I think, as Michael said, to look at the social determinants of health and not just at a general practice consultation.
Thank you. I know we have Dr. Paul Bout from the Northern Territory with us. Is he anywhere? Has he left the... Yeah, could you give us just your reflection or a perspective on our discussion, Paul, before we move on?
Well, look, thank you very much. And I forgive Ken Wyatt for mistaking me for a West Australian. I am from the Northern Territory, and I've been there for almost 40 years, and my work as a paediatrician continues to involve visiting remote communities. And like Senator Di Natale, I am concerned that things haven't improved in a lot of these remote areas. He was speaking of his return to Tennant Creek. I think your focus on youth is important. Unfortunately, I have the strong feeling that if you're getting into your early teens, that it's too late. I think those first 1,000 days really are important, and that's where the focus really must be if we are going to close the gap in the future. It's not too long a stretch of the bow to accredit virtually every chronic disease in Aboriginal adults as starting in childhood. And we're getting more information about that through study of epigenetics and the various other areas. But I mean, those first 1,000 days are utterly important. I thought there was a sense of relief with the new policy or considered policy of no jab, no play, because we have in some of those remote communities the highest rates of immunisation in the country, but many of them have nowhere to play and certainly have no qualified preschool teachers or early childhood carers. I welcome your focus on the young, but I think it should be taken a bit younger. Plans to do that.
Ken, would you like to reflect on perhaps where the discussions come from so far?
In respect to focusing on 0 to 17s, what I want is the foundation years to be consolidated, and I'm not reconciling from 0 to 5. That time period, if we look at Mustard's work, we look at the work that was done by Fiona Stanley Institute, the work that comes out of Baker ID, then what you have is a foundation for the way in which we've got to focus on those early years. But the trouble is we seem to stop at the age of 5. And there are a whole lot of other childhood illnesses that are precursors to the chronic care conditions. We're seeing also in communities an issue that is emerging, and you're going to pick up I think it's the West Australian tomorrow, may have a horrific story on the level of abuse in a particular country town where there's somewhere between 20 and 30 perpetrators that have abused just about every kid in that town. So the reason I want to focus on the 5 to 17 is start to pick up those issues, because they're going to have long-term compounding outcomes that will have mental health issues. They're likely to manifest levels of suicide, early teenage pregnancies that are often, in some instances, not often, but in some instances are unwanted. Our vaccination rates are at 97.6%, which is higher than the Australian level. But the social determinants are absolutely critical, and I have a working group within the Department of Health working across the different agencies looking at how we address the 31% factor that impacts on the health of young Indigenous Australians. Because somewhere I've got to draw a line in the sand and say, if we're going to make a difference, where do we start? Because we've been doing 0 to 5 for the last 20 years, but I'm not seeing the improved outcomes in some of the onset of health problems. When I was in New South Wales, we undertook a study with Aboriginal prisoners within 2 prisons in New South Wales. And what we came back with from that testing, because we were looking at the onset of renal disease, we were finding in Aboriginal men the onset of renal disease from the age of 19 plus. But we didn't see it in non-Indigenous Australians who participated. So we started to go back and look at some of the causes of the cause. And I've got the department now having discussions around looking at the causes of the cause so that we can start to unpackage the upstream work that we have to do. Now, I won't be losing a focus on adults with chronic health conditions, but I want to try and change the paradigm so that we have a better outcome for the future. Because if we can get that 0 to 17 year cohort better cemented in their health outcomes and their social and emotional well-being and the strength of their culture and their resilience in tackling racism, then they'll be far better off for the future. They'll be far better off than my generation. I don't think we'll see the deaths at the rate that we do now, and I think we can work collectively to close that gap. That will take more resources, and I was seconded to Cabinet recently to talk about the Aboriginal Health budget, some of the redirection I need to consider, and areas that I identify as being underdone. So I get an opportunity within 6 months to go back to Cabinet with an outcome where I hope to see an increase.
Thank you. You may or may not know, but when journalists go into the budget lockup, the government very smartly, and not only this government, all governments do it. I can't remember which treasurer was the first one to do it, but they come up with a very glossy summary of what's in the federal budget. And it's really the treasurer or the government of the day saying, this is what we're doing that we think's terrific, and these are our priorities. And it's interesting that in the table of contents, there are all sorts of macro things, but Indigenous health isn't mentioned as something to. I'm not saying nothing's done, of course, but I'm just saying that there wasn't an issue that the treasurer of the day or the government of the day particularly wanted to draw to us lazy journalists' attention. But they did want us to notice something very much, and that is the thawing of the rebate freeze, which let's get onto that very contentious issue. And I was saying to some at lunch, when I heard Bill Shorten today, and I've been covering federal politics for a hell of a long time, 32 years or more, when I heard him say that the rebate question was a question of the patients and not the doctors, I thought that statement is a watershed, because you might remember even going all the way back to Bill Hayden when they tried to bring when they brought in the original Medibank, and then Neil Blewett when they brought in Medicare. It was a battle with the doctors, and the doctors were only looking after their own incomes. Well, now the whole debate, which I welcome, the whole debate has moved on when people realise that doctors actually look after patients, and to look after patients, they need support, financial support. And I think that would be something that doctors should welcome, and I think that they can welcome it, because I think the AMA, probably since Brendan Nelson as your president, has repositioned itself very well. So Michael Gannon, let's be very rude and answer the charge that the opposition politicians put not so rudely to you today, and that Dr. Paul Mara from Gundagai put in his Guardian piece the other day. Have you been conned by the Health Minister and the Prime Minister in regard to the thaw? Did they give you too little just to keep you quiet?
They're in for a surprise if they think they can keep the AMA quiet. The AMA is... a point is often made about the fact that not everyone pays to be a member of the AMA, but the truth is that we maintain absolute independence from any other body in the country. We don't take 1 cent from anything other than members' fees, but part of that gives us complete independence. The doctors in this room often have to be, they basically have to be a member of a medical defence organisation. They often have to be a member of a college. They don't have to be a member of the AMA, but that gives us a great moral legitimacy and absolute independence. So leading up to the budget, I'm sure Minister Hunt was hoping that I would say certain things to support the Liberal National Government, and I said I wasn't going to be able to say those things. The morning of the budget, Catherine suggested that I say a few things in response to the budget, and I made it very clear to Catherine that I was unlikely to read from her script. And certainly we don't read from the script of any other political party. I've said this in my speech today. I think the success of the AMA has been the fact that over this 3-day period, the most senior politicians in the country are all coming here to our little event and talking to us. And even Senator Di Natale wasn't bold enough to say, let's trash the $6 billion private health insurance rebate. The Labor Party are not here saying, we don't believe in private medicine. There is no chance that the Prime Minister will turn up tomorrow and dare say that he doesn't care about adequately funded public hospitals and looking after the neediest patients in primary care and the importance of general practice to the health system. So I think collectively that's a success for the AMA. We have not entered into a formal agreement with the government, but I just made it very clear to the Minister that I was happy to welcome initiatives that are positive for our patients. He knows very well that doctors would have liked to have seen the patients' rebate re-indexed on July 1 this year. He knows very well, and the Labor Party knows very well when they first introduced it, that we were not happy about the freeze on patients' rebates.
I wondered, Toby Hall, if I could come to you, how do you see the, well, if you like, the politics in the broad sense of the word of the rebate issue? Do you think that the budget has addressed what is in many ways a political running sore, but also that patients and millions of them around Australia, can come up against as they decide whether they'll go to a GP or be able to go to a specialist even?
I think the reality is, I think playing with the rebate is actually not answering the problem. And until we're brave enough to recognise that whilst we have an outstanding health system in Australia, that we have a funding problem across the public system, primary system and the private system, and that is starting to creak at the edges, I'm not sure we'll really get anywhere in the long term. I absolutely agree, everything should be about patients. And people don't go into medicine, I hope, just to make money. I think nearly all of them go into medicine to care for patients. And when you look at it from that perspective, I think the thing we've got to say to the federal government is we actually have to have a long-term plan for medicine. We need a long-term plan for health in Australia, and we don't have it. And playing at the edges is not going to help anyone. It's not going to help patients with chronic illness. It's not going to help people who are, as we talked about in Indigenous communities, who are effectively contracting chronic illness at a young age. And we need to fundamentally do what I think we've done in aged care, which is step back and say, let's put in place a long-term plan. And my goodness, why not actually stick to a long-term plan for a change? I think we've also got to step into a space where, and I think the AMA can play out very well here, where we say to both the major parties, enough of this yo-yoing with health. Actually sit down, get your act together and come up with a long-term plan that you'll both stick to, so we can ensure that we've got the right healthcare for our patients, which is what we all care about. So yes, I welcome it because I think it's good for GPs. Do I think it's the solution? Absolutely not, and it's about time we had some long-term solutions.
One of the things that's been pointed out to me that when eventually the indexation when the situation is returned to the situation before the freeze, that the increase will be pitifully small and put you back to where successive AMA presidents and the AMA have been making a point, validly in my view, that the whole indexation design was pitifully inadequate anyway. I wonder if you've got a thought on that, Dwayne Crombie, from your rather privileged position on private health insurance.
Well, actually, I think I agree with Toby. You're actually looking at the wrong problem. I mean, if you step back and said, how much do we spend on health in this country? It's just on the OECD average. It might be a touch under, 9.9, 10.0%. But interestingly, if you look at the shares, the government spends less on average than an OECD country, and individuals spend more. In fact, I think individuals through PHI and co-payments are second or third in the world for out-of-pockets at the moment. So if anyone's got a right to complain, it's actually individuals in this current system. The current budget crisis is not caused by health per se, although obviously health spends quite a bit of the government's money, so it can't live in a different world. But I think, fundamentally, if you don't start thinking about the big picture about what kind of system you want, and I think any healthcare system in the world, if it doesn't have a really good primary care system based on general practice, I would have to say, the style of whatever it is, $37.50, kind of for a quasi 6-minute consult's never ever going to inspire, I think, the kind of primary care that you need in this country. And the trick is, how do you trust either government to make the transition to a system which gives more emphasis and bluntly more funding? I mean, just to wake you up after lunch, I think the gap between what GPs get paid and what procedural specialists get paid is way too big. I mean, we're all doctors, and why is there such a difference in how much people get remunerated? And I think we do too many things in hospitals that we could do in the community with more support. So for me, you can argue about the rebate all day long. That's not going to solve the problem. And we need politicians and we need leaders, wherever they come from, to actually think about the kind of system that we want to create. And a lot of the stuff that Steve Hamilton and the Primary Care Advisory Group suggested is really good stuff. And we should be actually trying to make that happen in this system, not get bogged down in puerile debates about the rebate. I mean, the rebate actually went up 4% in the last 12 months. The price didn't go up, but people claimed more codes, and people obviously with an ageing population. So you're kind of like, you're buried at the wrong level.
But Elizabeth Miles, as GPs, I mean, $37, or if it goes up with indexation to what, $37.50 or $30, this is clear, whatever it is, it's very small. It's simply not adequate enough. And of course, the federal government, as the monopoly buyer, as it were, can call the shots. But isn't this maybe an area where the rebate is in fact a real battleground?
Look, the rebate is a battleground because $37 goes nowhere near providing a quality care consultation. It'll provide a triage, so you can have someone, as Dwayne mentioned, maybe somebody comes in for 6 minutes and we can see them and we can say, yeah, go to the specialist, go to the ED. It doesn't allow us to actually manage patients. And so we are left with either a very large gap to fund a quality consultation, or else, if we want to maintain bulk billing, and that is frequently mentioned, and the reason why it's mentioned is because the sickest people in our community can't pay. The elderly, the people who have disabilities, the people with mental illness, Aboriginal and Torres Strait Islander people, all of those people carry a huge burden of disease and they have no money to access care. And GPs are, they are looking after them, and for that reason we want to be able to provide a service, but it winds up being a triage service, which pushes people into secondary and tertiary care, which is the most expensive place to be dealing with these issues. So the chronic underfunding of general practice is a huge issue. The $9 million I worked out is about a bit less than $5 a week per GP, paid for maybe one dressing, but rents continue to go up, our salaries continue to go up, the cost of all our consumables, our ECG machines, all our bandages, all of those things go up, and it's squeezing general practice at the very time we actually need to build primary care if we want to have a sustainable health system. And we can't do it by continuing to keep primary care, secondary care, tertiary care, all the separate entities, and not looking at the system as a whole.
Has anyone in the audience got a comment to make or a question to ask or a disputation? Yes?
Hi, it's Professor Sanka Mitra here, consultant medical oncologist from Fiona Stanley Hospital, Perth. I think there's a slightly long comment, so please bear with me, but I think it has an important bearing on the current debate. And the point here is, what is the battleground? And Professor Toby Hall discussed, and Dr. Elizabeth Mars discussed as well. And if you go back to two comments Albert Einstein made, one was sort of about insanity, which is insanity is doing the same thing over and over again and expecting different results. And the second comment he made was that you can't solve the world's problems with the same kind of thinking that caused them in the first place. And to me, the key problem in health, and this applies, I was in the UK for 19 years, only came to Australia last Australia Day. And it was the same problem with sort of overboarding in emergencies, sort of 20 ambulances outside emergency, A&E waits sort of going up. And the key is the acute cost of hospital care and really trying to get managed chronic care in the community. And the fundamental problem is, if you look at it, goes back to the history of Western medicine. And if you look at history of Western medicine, it started with Lister with antisepsis, sort of, and carbolic acid. And then it was led by predominantly surgeons between 1890 to 1940. And if you look at those surgeons, there's something peculiar to them. 99.99% of those surgeons were males. So what we implicitly practice is a very masculine version of medicine, and that's reflected in the structure of our acute hospitals. So it's very patriarchal. It's sort of, you come in with any problem, we'll sort you out, you get better, and then you get home. And that model of care worked for 50 years, because if you have someone with acute appendicitis, you don't even need to say hi or hello to the patient. You put the patient on the operating table, cut that tummy, remove the appendix, and send them home. They're fine. It worked with acute pneumonia. You give them IV penicillin, they're cured, they go home. But what happened was, over the last 50 years, the demographic of illnesses changed, and we moved from the acute illnesses to chronic, incurable conditions. We moved into diabetes, we moved into care of the elderly, we moved into cancer, we moved into chronic heart failure, chronic renal disease, COPD, none of which can be treated in an acute hospital setting. So what you have to fundamentally define is, what is the purpose of existence of an acute hospital? Why does it need to be there? And who needs to be in an acute hospital? And the answer to that is anyone who has an acutely reversible medical or surgical condition. Anyone who doesn't fit that condition should be managed in chronic care in the community.
Well, it's interesting, and I think we do need to move on to this, the role of private health insurance and private medicine. Would you like to pick up on that?
Yeah, well, it's an interesting one. I'll just give you two examples, because I think one of the issues being discussed in the National Hospitals COAG agreement, I think, between the Minister and the states is, in the past, if a state or hospital produced an output like an admission, they would get paid 45% from the feds and the rest from the state. But if they did something in the community, under the current agreement, it's very hard for them to get credit for it. And in fact, they'd lose money because they didn't have the admission. What they're discussing is, what could they do around non-hospital substitution where they could count that for something, so that you would give the states some incentive, because as you know, the states are a bit obsessed with not funding things that they think the Commonwealth should fund, and so we've got this slight perverse set of incentives. You've got the same issue with private health insurers, where if it's something in the community that Medicare funds, we're not allowed to fund it. In other words, and this is not about us taking over general practice or primary care, but if I wanted to do the right thing in the community and not, you know, I could pay for someone to be in a hospital and pay $7,000 or $8,000 for a 2 or 3 day stay. But if I wanted to pay for an intervention in the community that somehow had a Medicare item code, I'm barred from that under the current rules. So you've got kind of, you know, you've got landlocked incentives for people not to do the right thing in the system. And it seems to me the more we can free up, you know, some of the system, because a lot of these counting rules are about control. They don't trust anybody. You know, we don't trust people, the Commonwealth doesn't trust, but nobody trusts anybody to do something different from what the official item code is. And so somehow we need some flexibility to do the right thing for the patient.
Well, I've got to say to you that if private health insurers think that they're part of the solution, surely they would have had to been performing better than they have as far as the public is concerned up until now.
I mean, one of the issues that the public are upset about is the 5% price rises each year. But if you step back, virtually every public or private system in the OECD runs at 5 to 6% in terms of cost. About half of that is cost of living, the next biggest is ageing, and then you've got technology and clinical...
No, isn't the bigger problem rather the gap, what they are not covered for by their private cover?
Yeah, but I mean, I'm getting to that. I mean, the fact that the system, if you don't do anything, the system goes at about 5 to 6%. And what private health insurers done, rightly or wrongly, to a group of the population who just say, I can't afford this, is the only way to make it fit is to take stuff out of the product. Whether you think that's a good idea or not, private health insurers are responding to a bunch of consumers who are extremely price sensitive. And that's why you're ending up with product that's not so good, because it's not comprehensive. I don't know whether there's an easy answer to that problem, because I mean, if you can show me a healthcare system that's really good quality with an ageing population that's running at less than 5% a year, I'll be absolutely surprised, because there'll be some really blunt rationing going on in that system. Exactly, but that's the problem. I mean, the one area where we should be putting more money in is the problem that's been deeply rationed, and that's not good. And I think, I mean, all I'm saying is that some of the flexibility, which everyone would agree, we need to figure out a way to design it into the system to achieve what you think, all of us believe in, actually.
Well, Toby Hall at St Vincent's Health, if I remember or know, if I'm correct, you've got two big emergency wards, hospitals, Sydney and Melbourne, right?
Yeah, we have, yes.
And are you having to pick up the people who turn up to emergency because they can't get the care they need or feel they can't get the care they need in their local doctors, whether it's after hours or they're not there?
Look, I think firstly, we have absolute respect for the quality of general practice across Australia. With our emergency departments, we do get a number of people who come there, and I think to some extent there is often an irrational fear of gap fees, and I actually think this is something across the health system which is a problem today. The reality of people's perception of gap fees versus the reality of what they are is quite different. And so a number of people are coming in appropriately to emergency departments. The cost of that is very high. Probably more than that is also the issue of people who are coming through who are really inappropriately coming to emergency departments. So we would estimate about 40% of the people who come to our emergency departments are people who are really seeking support for chronic illness, support for mental health issues, support for drug and alcohol issues. And to Dwayne's point, generally speaking, these should be served in the community by general practice. And there is no doubt that the people in the community practices have the ability and the skill to deal with those people and treat them effectively. However, the system to an extent is broken. They're not funded well enough to do that effectively. And tinkering around between $37 and $40 a patient is not going to make the difference. And we actually have to fundamentally step back in and say, how can we deal with the health system differently? Now, whether that's looking at accountable care models, like they've looked at in the States, and there's some great models of those, and there's some appalling models of those, whether it's looking at capitation models, whether it's looking at models like hospital in the home, we've actually got to come up with a better plan for the long term. And frankly, I can tell you now, it doesn't matter if you unfreeze the Medicare rebate, because we're going to have the same problem, but a little bit more money going to GPs' pockets, which might be good, but it's not solving the issue for patients. It's not keeping people out of emergency departments. We actually have to get in and be prepared, all of us, to remodel the system, which means I am quite happy, to your point, and I agree around the issue of chronic illness, for St Vincent's to give up patients to the primary healthcare system for the good of the patients. I'm also quite happy for our clinicians to have less acute surgery because the surgery is not needed. And we need to put our hands up and say we're happy to do that. But across the health sector, that means GPs and specialists have got to stand up and say, we're going to join the party too, which means we're going to be prepared to change, do things in a different way. We're going to say to patients, actually, that operation is not going to help you and we're not going to do it, rather than saying, let's spend the money on this operation, which is not really that beneficial for patients. So we all need to be part of the solution.
Elizabeth?
Well, I would support that, but I would also say that those conversations take time. Even somebody coming in saying they want antibiotics for a cold, it takes 20 seconds to print off the script. It probably takes 5 minutes to explain why they don't need it. And certainly, if they want referrals to various specialists, and they come in, they want referrals for another gastroscopy, even though they've got no family history, they've had nothing wrong. They had a colonoscopy 3 years ago. So there is a demand that we need to address, but we also, you can't expect general practice to do more unless you're actually going to fund primary care to spend the time. I mean, we just can't do it.
And I absolutely agree with you.
Yeah, sure. Have you got a microphone?
George Santoro. I'm impressed by a bunch of philosophers around here. I was in solo private practice for 40 years, and I would have kept 100 people out of hospital in that 40 years. Firstly, there was parking. And what happens now, they're all apartments. There are blocks of apartments without parking. The doctor can't go. There's no possibility. So when I got there, I'd walk upstairs and see them, and I would take the script back to a chemist that would deliver within an hour. In my practice, which was prolific, I would use specialists that repaid me with a kickback. They would go and see a patient of mine at home, or I wouldn't send them anything else. That's final. I would have kept 100 people out of hospital, and I'm surrounded by a bunch of philosophers. More apartments, more hospitals. That's all there is to it. You try and get a parking fee. I've had 2 deaths because of freeways. Wasn't my fault. I will not break a speed limit or a parking even if a death occurs. I don't go as far as breaking a law. I'm listening to a lot of philosophers here, but you can do the home calls. You ring the relations and you say, go and look after your mother for a week or she'll be in hospital. Very simple. I've done it successfully with no objections, no criticism or no claim for 40 years.
Where were you practicing?
Richmond.
Right.
Victoria.
Mm-hmm. That's interesting. Yep.
But I'm impressed by philosophers around here. I'd rather do the home call. Thank you.
Yeah, well, you have just got a different philosophy.
Richard Kidd, I'm Chair of the AMA Council of General Practice, and I would echo some of what was said there, and I would challenge Liz. I fully appreciate and agree with what Liz is saying about the pressures on general practice to try and churn. But the reality we know from Beach and other studies is that GPs spend on average 14 minutes per consultation, not 6, and deal with multiple problems in each of those consultations. And we are doing a lot of that work now. We are under terrific pressure. Some of the models that are bubbling up around coordinated care have come out of the work that general practice did initially and did the research on around the coordinated care trials. So, we've done the work. We've shown why these things will work. I agree with Dwayne that there's some issues around how to get private health insurance and other funding bodies to better resource general practice to do what we know we can do well. And yes, we should definitely be much better remunerated. But the reality is we are doing a fantastic job in Australia, but we're at a tipping point and we really do need help because we will fall off the cliff.
Okay, thank you. And down the front here. Oh, sorry. No, over here. You're out of my... Yes, please.
Brian Morton. I'm a GP in Sydney. Call myself a full-time GP. I was part of the Minister's Health Advisory Group. I now have 2 roles in regulatory professional bodies for doctors. What I'm seeing in those roles is a diminution of quality care, a high throughput, a poor consulting style with very little time spent with the patient, which drives the move to hospitals, to EDs, to poorer health outcomes. We are at the top of the OECD outcomes for a number of things. We're about to see a fall off. And I'd like to see the panel actually give some practical ideas of how we're going to change the system, because a lot of it is mere rhetoric, because you say those things but then nothing's changed.
But can I just come in? Doesn't it come down to the fact that for doctors to survive, that is to pay the bills and to have an income, you've got to have a large throughput. So, you've got to have people coming through the surgery.
In my area, fortunately, I'm in a higher socioeconomic area, but it's the Robin Hood principle. And those who can afford to pay subsidise those who are indigent or disabled or pensioners. And we can't have that system going on. So we need to see that international evidence that shows a primary health system that's strong is actually funded and supported. Why did the Minister not appoint anyone from the Healthcare Advisory Group to any of the implementation plans? Simply because health is managed by finance, not good health outcomes. We need to see both political parties actually take up the baton to support good healthcare independent of the financial control of departments in government.
A lot of people want to comment. We have down the front here. Oh, we've got a mic up the back. We'll get a mic to you very shortly. In fact, you're next.
Oh, hello. Oh, hello.
Sorry, yes, please.
Yeah. It sounds like we have a situation where the most effective part is rationed and underfunded. The most ineffective part is overfunded. And we keep searching for practical solutions when it seems like our actual problem is our funding models are completely wrong. And we can keep toying with more effective services which everyone delivers, but when are we going to fix the funding models? We've got state, federal, we've got all sorts of different bodies funding all sorts of different things, and on the ground the doctors keep trying to improve things, but it's actually the funding models that are completely wrong. Just a comment.
Okay, down the front here.
Gino Pecoraro, I'm an obstetrician gynaecologist from Brisbane. Going on from that remark, really whether it's a private health insurance product or a government insurance product called Medicare, it really is all about the funding model, and that's what's broken. I can see patients who are overseas travellers and they have an insurance policy which they pay, and out of that insurance policy, it pays for quality general practice, the entire cost of quality general practice. If they come to see a specialist like me, it covers all of my fee, it covers all of the costs they incur in hospital, including things like drugs, dressings, post-op pain relief and physiotherapy.
How expensive is that covered, you know?
I don't know, but it's enough that those travellers can fund it, can buy it. What I'm asking is, if that's the problem, that we don't have a decent insurance policy from government or the private sector, why can't this be opened up to the world? If Australia can't find an insurance policy that works, why can't we go to the international community and say, we've got 24 million people here, we're going to buy 24 million policies, who can give us the best deal that covers everything? Why can't it be opened up to pure commercial things like that, so that then everybody gets a policy that actually means something? Because at the moment, Medicare means nothing. The Medicare rebates never cover what the patients have to pay for services, and private health insurance has become hospital bed insurance because it doesn't cover most of the costs of the doctors or ancillary care.
Okay, Dwayne, I think this is over to you, but last time I had to buy travel insurance, it was extremely expensive. Anyway.
Just dealing with that, because we actually are the biggest provider of insurance to overseas visitors. I think we have about 55% of the market plus a whole lot of students. But the difference is, in the main, people on that kind of insurance are generally working age or student. So in the scheme of things, the policies are not that dear because they're not over 65, where a lot of the costs are borne in the system. I mean, when this system was set up, and I think the last incarnation with Woolridge and Howard, it allowed, I mean, Medicare is the insurance system that includes primary care and ambulatory care. That's the way the system was set up. And the way private health insurance is set up is pretty much a focus on hospital, excluding emergency and ambulatory and primary, and we're absolutely not allowed to go over that boundary if Medicare's got an item code, and dentists and optical.
Why do we have to stick to that?
Well, I think you saw in the last election why neither government will touch the sacred cow called Medicare, so that will never be privatised. And the question is, the government of either persuasion, Ken or his counterpart, are not particularly keen to stump up and fund the bit that we think should be funded properly, which is general practice and primary care. I mean, I just tell you that's the political reality at the moment. I mean, it's just stuck in gridlock, really.
When you say it's stuck in gridlock, I think what it comes down to, and what we saw in the last election and indeed many other elections, is that the Australian public believe that the provision of good health services is something they expect from their government. What does the government minister on our panel think of that?
There has always been expectations in terms of Medicare that it's sacred, that government shouldn't touch it. It's the foundation for people relying on accessing all levels of healthcare. Part of our debate has to be around also encouraging people who can afford health insurance to take it out. But the challenge I have will be when I hit 65, because I know that the health insurance funds are going to be asking me for more. And we've got this conundrum of over this age bracket, because when I was at the G20 Health Ministers Forum, we had a similar discussion around what the states fund, or what the nations fund, and private health insurance, even for aged care. There was, we were made aware of health services in aged care now is taken out through insurance. So globally, there are some challenges for other sovereign nations in the way that they're trying to address aged care and provide fundamental health care within their jurisdictions. And whilst they've got good systems, I was talking to Netherlands, and the minister there made it very clear, he said it's becoming unaffordable. And it's a challenge for governments. And Australia will face the same issue given we've only got 24 million.
There's only 3 countries with community rating like Australia: Australia, Ireland, South Africa. And part of the reason why health insurance is so costly is everyone bears the cost of the over 65s. In other countries risk-rated, where the older you are basically, or the sicker, you pay a lot more insurance, you don't get private health insurance because most people can't afford it. And those people in places like the Netherlands and New Zealand all fall back into the public system. So that's a different kind of model, and I don't know whether we would like that model in this country, but that's the kind of tension that we've got in this thing at the moment, that if private health insurance becomes unaffordable and people exit, particularly older people, the government and the states will get it all back in the public system. So that's the kind of balancing point at the moment.
I think one of the things which is interesting is that essentially, and a couple of people have asked for solutions, in the absence of putting primary care together with secondary care from a funding point of view, I don't think we will ever resolve the funding issues that we have. And the reality is that in most fields, and I would guarantee in this room I could probably pick 20 of you, and you could come up with a better model of the healthcare system than we have today. And in every field I go to with health professionals, I would say pretty much the same thing. There is no lack of understanding of what we need to do. There's no lack of ability in terms of doing it in Australia. There's a lack of someone who's got leadership skills standing up and saying, we will make this happen, we're prepared to make big changes, and changing how primary care is funded and linking it more closely to secondary acute care is a big challenge and a big change. But they've done it in America, and for crying out loud, if they can do it there, surely we can get our act together and do it here.
Sorry, where'd you say they've done it?
They've done it in America. They've done it very successfully.
Are you holding America up?
Parts of, Kaiser Permanente, to be fair, has got a great model which I think could operate very successfully. It doesn't have to be privately insured. It can be done through government funding. But unless we bring the financial outcomes together in terms of the primary system and the secondary system, we don't have the incentive to really deal with what the future of disease is, which this gentleman articulately put, which is actually chronic illness. And we have a funding system which was right for an acute system, which is 30 years ago, not for a chronic illness system, which is what we have today. We have to remodel the system if you want solutions. It's doable, we know the answers, it just takes political bravery.
Hello, my name's Sarah Whitelaw. I'm an emergency medicine physician from Melbourne, and I just want to mention emergency medicine, talk about a tipping point. We are the fallout for the lack of resourcing for our GPs. It's the emergency departments whose role and demand has increased exponentially over the last 20 years, with absolutely mismatched incremental increases in funding and staffing resources to meet those demands. And I would just put a plaintive cry out for when we are developing our community care and inpatient illness coordinated programs, when we're looking at revision of funding models, that we don't forget about emergency medicine. We don't forget to communicate with them, we don't forget to seek their input, and we don't forget the funding and the resources required for the emergency department role that invariably comes out of any of these revisions.
Thank you. I take that as a comment. Right at the back, is it? Oh, okay. Whoever's got the microphone, that's power.
Jeff Hawson, medical oncologist from Queensland. I also represent one of the over 65s, and it's $6,000 a year for my insurance at the moment. I don't know how the general public can afford that. I mean, I retired last Friday, and I don't know how it's going to be paid for in the future, but everything here is very GP centric. As a medical oncologist, looking at the drugs that we have potentially to treat patients, I don't know where the money is going to come from. We have drugs that cost $40, $50, $60, $100,000 a year, and for some of the trials for one of the drugs that costs $100,000 a year, there's currently 600 diseases or trials going on. We're talking about how we're going to get another 50 cents for a GP consultation, how we're going to get hundreds of thousands and millions of dollars. It's something that I think when we're looking at issues we're facing in 2017, it's going to become a real problem.
So, Dwayne, you've got to solve it.
Well, I mean, I'll give you a far more common example. A hip operation with 2 weeks of rehab in some Sydney hospitals cost me $35,000 on your behalf as a member. And you would pay $6,000 for a good hospital product regardless of your age. So the question, how do I deal with the $35,000? Because under the current system, I'm a price taker on your behalf as my customer. That's one of the conundrums we have in the system. And you don't really want me or someone in Canberra telling you whether you can have your hip or not. That's not what we need in the system. But the question is, how do we challenge some of the costs in the system, which to me seem pretty breathtaking?
And we have a question at the back of the room, standing.
Hello, my name's Corey Lee and I'm a GP from WA, and my question is to you, Dwayne. One of the real challenges we have is challenging the health misinformation that's out there from professions such as chiropractors, and they're validated by funding from private health insurers, and I just wonder when you're going to make a difference there.
Closely, and I mean, it was interesting because we're watching the Department of Health. They've just done a review of all of the complementary areas, and in the end, I think apart from about 2, they pretty much backed off it because, to be really blunt, the focus polling with the customers was so negative about taking that away. But we've looked at Bupa. We spend about $52 million a year on complementary therapy, of which the biggest spends $37 million on remedial massage. And I can tell you, we talk to our customers, the idea of taking that away from them is a nightmare. But certainly we're looking at a bunch of the other ones that don't make sense. But I can tell you it adds up to less than about 7 or 8 million on a $6 billion spend in my claims line. So yes, I can take that away. It saves 0.1% of my claims cost. And we are actively looking at that for the 2018 pricing round.
Toby Hall, when we come to talk about private health insurance, of course, this is absolutely crucial to big private hospitals like the ones you run. What is the problem there, or rather, what is the answer? What's your view on it?
The answer is somewhat complex, and the reality is if we want good private health care, we are probably going to have to ask people to pay more for it. And the reality is there's a number of products which people have been sold as private health insurance which are actually bordering on useless, and these are not my words, but they're used by the previous health minister. There are junk policies which people have been sold by private health insurers. That's a tax avoidance product, it's not a private health insurance product, and so we need to address that. I think the concept of the bronze, silver, gold platform which has been looked at is a good model, and we have to really ask ourselves, do we want to have a quality private health insurance product which actually provides access to private health insurance? And if we do, people are going to have to pay a little bit more. That's going to take some political gumption, but the reality is it takes pressure off the public system. It allows people to actually access what they're paying for. And I think there's nothing worse than people coming to our hospitals who believe they've got insurance and finding out with a specialist they don't. And I'll give you a classic example of this. An 88-year-old male coming to the hospital for a hip replacement is covered for obstetrics, but not for orthopaedics. And you look at that and think, how does that happen in this age? It's bordering on criminal, but that's the reality of products people have been sold. So we have to sell high quality products. That is going to cost more, but I think that is something that actually is going to have to happen across the health system. Those of us who can afford to pay more, I think if we want the health system we have, are actually going to have to put our hands up, whether it's additional funding from our own pockets for GPs, whether it's a higher health insurance cost. We are going to have to do that. At the same time, we need to encourage ensuring that the service which is provided in private hospitals are actually necessary services. And I think the MBS schedule review is quite appropriate. We need to support that and make sure that what we're doing is valid. That said, once we've done that, let's make sure we've got a high quality insurance product that people actually get value from. And I think if we can do that, that'll be a good thing. And I think the insurers should stop selling junk products, basically.
I think people kind of think health insurers are the big problem sometimes. The industry operating margin for the 36 health insurers is about 5%. And it does come to a big number because there's 22 billion spent on private health insurance. If we all got together, the 36 of us, and said next year we're not going to have any price rise, that would effectively wipe out all of the operating profit in health insurance for that year. But in 12 months' time, healthcare costs will have gone up by 5%. And we'd have to put up prices by 5% simply to break even with no profit, and that would happen every year after. I suppose the point I'm making is unless we have got some novel way of changing the rate of growth of healthcare costs, health insurance is going to keep going up like this unless we're prepared to take stuff out of product, which obviously is not very palatable, encourage doctors not to do things that are low value, like spinal fusions in the lower back, find ways to stop providers spending. I spend 170 million on mental health each year, of which 93% is on inpatient mental health. And we know that a lot of those people could be managed in the community, but the system encourages people to make a lot of money by putting them in an inpatient bed. But it's really hard to change that, because unless doctors want to take that leadership role, the system's set up like that. And that's the kind of challenge we need to face.
The delegate with the microphone.
Thank you, Ines Rio. I'm a GP, the chair of the AMA General Practice section, and also the chair of the North Western Melbourne Primary Health Network. I've heard a lot of furious agreement, really, that we should be strengthening the primary care sector and moving a whole lot of care back into the community, and for that to be sort of a wraparound service. And I was absolutely delighted to hear that James has decided to become a general practitioner and serve his Indigenous community. But with the great discrepancy that we have between primary care funding and secondary and tertiary funding, we're seeing the changes in workforce that reflects. When I became a doctor, which I don't think was that long ago, about 80% of us chose to become general practitioners. Something like 4 out of the top 10 in our year became general practitioners. Now I think it's sitting at about 10 or 15%. Once we embed a system where most practitioners become specialists, this is going to be very, very hard to do. And so I just put it to us that there needs to be a redistribution of the money that we have. We're always going to have a finite amount of money. The AMA as an industry organisation in some ways is always going to say we need more money, perhaps we do, but we do need a reallocation of power and influence back into primary care and general practice.
Thank you. And there's a lady at the front here. Oh, if we can get a microphone down here. Who's got the microphone at present? Power. Yeah. Oh, sorry. We'll come to you. We will have Liz on the panel.
I just want to, I completely agree with you, but I also want to make the point.
Okay. That it also comes down to workforce planning and the workforce that we create. If we don't have workforce planning, and we saw a few years ago, the number of specialists in this country actually start to outnumber the number of GPs. So we are moving towards a much more specialist-focused workforce. And unless we address that issue as well, we are going to wind up with a more expensive healthcare system. So we need to shift funding, but we also need to look at actually planning our workforce so that we're producing more primary care practitioners and fewer specialists.
I wonder too, if we do get to that, will we have a less holistic approach? If everyone's specialist in a little finger and they forget about the big toe on the other foot. That's facetious, but you get the point. Oh, yeah, sorry, Mike.
That's a really important point. I mean, I think that Dwayne will tell you if you look at his actuarial data, we talk a lot about the things that grow the cost of the health system. We talk about ageing, etc. But it's the cost per admission which is driving the growth. Now, the general practitioner who assists me every Wednesday morning, non-member, but we won't talk about that. He calls me a narrowist. He doesn't call me a specialist. And one of the, I'm glad someone's mentioned workforce here, because we've got this so wrong. We no longer have general physicians, even within hospitals, who have the ability to deal with everything. And you end up, if you've got a high sugar level, you get to see the diabetologist, and you have an episode of rectal bleeding, you get a colonoscopy, and if someone spots that your creatinine's off, you get to see a renal physician. So we need to get smart in medical workforce and training as well. I think that we need to re-pivot. I don't think that there's furious agreement through the room about how general practice is undervalued and underdone, and I think that we need to do whatever we can. Maybe that means having the difficult conversations about private health insurance and general practice, but there are some real sacred cows in this area. We saw that at the last election. One of the things I'm sick of is whether it's Labor or Liberal or anyone else looking at the bulk billing rate as the metric of quality in our health system, because the bulk billing rate of item 23 is not a measure of how many people stay alive or better quality of life or any other measure, but there is an obsession with it. And one final comment I will make is that one of the privileges of this job is that you travel overseas and talk to doctors from other countries. There's not a country on the planet that's worked this out. There is year-on-year growth in the cost of healthcare in developed countries around the world. We've got so much right in this country. I think the political reality is that it's going to require tinkering around the edges rather than really broad reform. And yet I think that what you've heard in this room is you've heard GPs have heard all the other specialists tell them that we recognise the quality of your work, and we want to do our bit for that to be recognised as central to the whole health system.
Thanks, Michael. Lady with the microphone.
Is that on?
Yep.
I'm Kath Browning-Carmo. I'm a specialist, and since I graduated I've always thought of GPs as specialists, so I don't see there's a difference between the craft groups. As a neonatologist, I would say that we do need a broad change in focus if we're going to close the gap, tackle obesity, address our mental health issues. As a village, we need to galvanise ourselves around pregnant women and make sure that they get the care and the health that they need, so that when they have babies, they're well educated in infant nutrition, infant attachment, and how to develop a child in those first 5 years. So I really want to echo what Paul Burt said, in that the first 28 days is really important, and especially the first 5 years. Every dollar you spend early on in life has exponential return over the lifetime. So if we can change that focus, we'll get much better health outcomes in the future.
Thank you. And there's another person with the microphone. Is it on? Yes, it's on. Just talk.
Talk?
Yeah.
Sorry. Rob Parker, psychiatrist from the Northern Territory and AMANT president. This is going to rewind a bit back to Ken Wyatt. In 2008, Ken Henry, who was a very influential figure in government, took an economic theory, attached some WHO principles, and added, I think, $4 billion worth of federal funding over about 5 years to establish the National Indigenous Reform Agreement, which was a sort of strategic, I mean, with the Indigenous health problem, a lot of it is social determinants. So if someone's living in a house with 10 other people, it's not much good trying to fix their ear problems if they're going back to a house with 10 other people and all the environmental issues that goes. And at least with that agreement, it set some sort of strategic view about a broad range of social issues as well as health issues. I'm just wondering what's stopping the government adopting similar programs currently, both in Indigenous health, possibly even in mental health, where you've got the same broad range of issues to deal with across a range of departments.
Ken?
Just on that, the National Indigenous Agreements came out of the COAG agenda established by Kevin Rudd. And there was a $1.6 billion allocation of funding to address a raft of those issues. The Commonwealth led with that by distributing money to those states and territories that bought in at various levels. The problem with national partnership agreements is the implementation phase. We can have the intent at the national level to set targets, and the same issue applies with closing the gap. Unless the implementation phase at the state and territory level is followed through in the same spirit of intent, we're not going to see the changes. The challenge that we will continue to have is the impact of the social determinants for some period of time, and the quantum of money needed just to address housing is substantial. And I know that Minister Scullion is seeking an increase in housing infrastructure and community infrastructure budgets to try and address that.
Thank you, Ken. I'll just let you know, the clock tells me we've got 5 minutes to go, so we're running down. We won't be able to get to everybody, but we have someone else with the microphone. Sorry, there you are. Sorry.
Hi, I'm Alison Sorensen. I'm a GP registrar in Western Australia, and I'm the Registrar Advisory Group Chair for WAGPET, the GP training organisation in WA. I suppose everyone's got an idea about where we need to be spending funding, but I've got significant concerns about how the funding's been restricting to GP registrar training. GP registrars are going out increasingly into corporate practices where our focus is on financial return and not on patient care, and it's my personal opinion, but I think it's shared by lots. And my concern is that registrars, under the national terms and conditions for employment of GP registrars, is that they go out on a base salary that's less than what they earn as an intern. They are then taught to rack and stack, as some entrepreneurs teach how to use the MBS as a way of, again, making money rather than focusing on what really primary care should be about, which is maximising patient health. So I suppose, and again, even simple things, so we've got an increasing number of women going into general practice training. There's no provision for paid parental leave for GP registrars. This is because of the way it's funded, being a private service or being employed by private organisations. So I would implore those, both the AMA and in general, that we need to have a focus on what we're actually teaching our GP registrars. They're not coming out with the skills of the GPs in times gone by. I had the privilege of working with the immediate past president of the college as a GP registrar and seeing the skills and the complexity. I think I'm the only registrar in my region that retains hospital admitting rights because that's still seen as an important thing, what GPs can do when they can admit their own patients to hospital when you blur the line from primary to secondary and tertiary care. So please think of the GP registrars.
Well, plenty to think about there. Look, we're just out of time. So I thank you all. There are plenty of hands up, and no doubt over dinner tonight or over a drink you'll be able to continue this very interesting and important discussion. I'd like to thank the panel very much today, especially the Minister for joining us on what is really an auspicious day in broader terms in your portfolio area too. There was so much more we could have addressed, but I think we see that that people are committed and passionate, and that's extremely important. I don't know whether any of you have noticed it, but there have been a number of opinion polls. There's been research done over the last few elections, and Australians, no matter who they vote for, actually are grateful when they look at the United States of America that they live in Australia, and one of the key reasons is that they believe that Medicare offers them better health care than they'd be getting if they're in the United States. Now, that there may be misconceptions and all sorts of things in there, but that's interesting that is an attitude that a number of opinion polls have picked up over recent elections. So thank you all very much for your contributions, and I wish you all well for the rest of the conference. And one last thing, having been a political journalist for so long, you do need to use your clout if you want to get anywhere with governments, local, state or federal. Thank you.
And that's that. All right. Well, thank you very much, Paul, and to the panel. That was a terrific session to get the conference off to a flying start. Okay, so we're going to break now for afternoon tea, and we have 20 minutes. The afternoon session includes the presentation of the role of fellows, which is open to everyone, and the AGM, which has a restricted attendance. Could all relevant people please register for the AGM during the break? You'll need your voting card. Thank you very much. See you in 20 minutes.